So the second talk is Dr. Lorenzo Garagnani, and he is a consultant orthopedic hand surgeon and FISOS, that is an international group of pediatric hand surgeons that specialize in the treatment of congenital hand differences. And a council member and the first president of the FISOS meeting. So today he talks about the Madelung deformity. Are you ready for the presentation?
I am ready indeed.
Yes, thank you.
I'm sharing now. Can you hear
Yes,
me?
yes.
Perfect. So good morning, afternoon, or evening to everyone, because that depends on where you're connecting from. Thanks Takehiko and Andres for the kind invite. Thanks to the PULM group for these webinars, and again, which are extremely interesting all the time. I've been talking about Madelung deformity today. It's something that we all deal with. We all see quite regularly in our clinics, sometimes in adults rather than children, sometimes in children or teenagers more often. And again, it's something that needs a bit of clarity because there is a bit of confusion sometimes on what is a Madelung, what is not a Madelung deformity. So I'll put some facts as well as my preferred treatment approach, and then we can discuss on any other approaches you have to this disorder. The etiology of Madelung is not always genetic. We don't know the exact incidence of it, also because a lot of patients do not present to us. A lot of patients are completely unaware of having especially subtle Madelung deformity, and they can continue to live a normal life without any symptoms or very, very limited symptoms, so they never present. Usually the true Madelung deformity, in order to distinguish it between true and pseudo Madelung types, tends to be bilateral. And that's what we can see sometimes when we x-ray one limb and we see a more marked deformity, and on the other limb, a very subtle one, very mild one. But pseudo-Madelung deformity can present very similarly as a consequence of trauma or infections, growth arrests. And again, if you're bowing of the radius, you may end up with similar patterns. The male to female ratio of Madelung, the true Madelung deformity, is 1:4, so is more frequent in the female group. The genetic cases can be or not syndromic as well. There are also syndromes which are not genetic, and they may have a Madelung type deformity of the wrist. So those are idiopathic cases of Madelung deformity. But these syndromes that you can see here are the ones that can, of course, present a bit more frequently to your attention, although they are all very rare. One is the Leray whale dyschondrosteosis, is probably the one we see mostly in our clinics. These patients have also a short stature because they got a mesomelic shortening of the limbs, upper and lower limbs, and that's all they have really. So they don't have any other life-threatening risks associated with this syndrome. You can have the dyschondrosteosis nephritis syndrome, very rare. Nail patella syndrome can also present with Madelung wrist patterns, and the hereditary multiple osteochondromas can also present, like the previous speaker was mentioning, with bowing of the radius, which actually represents a type of Madelung deformity. Turner syndrome as well. The features of Madelung are shortening and bowing of the radius, increased volar and ulnar tilt of the distal radial articular surface, so you see this change in positioning, and the carpus, you see it subluxing sometimes volarly, palmarly, because of the anomalous radial growth. The distal radial ulnar joint, although we still call it distal radial ulnar joint, and I also wrote it in my slide, as you can see here, it doesn't really exist because we don't have a sigmoid notch. We have a physis of the radius articulating-ish with the distal ulna, which is usually unstable, so it's not really a distal radial ulnar joint. However, to be able to orient ourselves anatomically, we call it druge. It's definitely wide because there is a dissociation between the ulna and the radial growth. The carpal bones tend to form a triangle, an inverted pyramid, with the proximal apex centered on the lunate bone. And you find on MRI and clinically when you operate on these patients an anomalous thickening of the volar capsule, which is called Vickers ligament, between the radius and the carpus. Another important part about Madelung deformity is that it can vary in presentation. So clearly, the patient you see here has a very severe palmar subluxation of the carpus. So again, you see also the deformity clinically and not just radiologically, but other patients can present to you with very mild types. Here, the radial bowing is marked. You can see the radius is quite short in comparison with the ulna. The ulnar growth is not affected, so the ulna continues to grow as normal. And in order to grow as normal, it needs to grow dorsal to the carpus. And that's what causes most of the symptoms in these patients, because these patients present to us when they start experiencing usually dorsal ulnar wrist pain, especially during wrist extension or activities that cause load-bearing, weight-bearing onto the extended outstretched wrist. However, we need to remember in our practice that not every wrist anomaly is a Madelung deformity. I've seen it all during my years of practice in different hospitals. I've seen patients refer to me, and maybe it has occurred to you all in your practices, refer to me with an anomalous distal radius and the short ulna, like the one on the left. Calling it Madelung is not a Madelung. The radial shape may remind the Madelung, but that ulna is actually in place, articulating with the radius and not longer than the radius, so it cannot be a Madelung. This has been something else. And there are also some cases of this type, as we all see. Some of them are idiopathic. And on the right side is clearly a malunion of the radius, so the ulna is long because of the malunion. However, it has been defined Madelung as a very loose term. So the problem is that the term Madelung deformity historically has been used loosely in the literature until very recently, when we started to differentiate between real Madelung, pseudo Madelung, and what could be Madelung. And again, it's still very blurred, but it's better than in the past. In the 19th century, any distal radial curvature was called Madelung deformity. In 1967, there was also a study describing a variety of different conditions leading to this deformity, but it wasn't really exactly what we call nowadays Madelung. As I said earlier on, some patients are not aware of it. This was a patient with wild disc chondrosteosis who presented to me at the age of 82. And she came to me only because of development of lack of extension of the little and ring fingers. So she had a Vaughan-Jackson syndrome with ruptures of the extensor caused by the ulnar abutment onto the tendons. So it was a caput ulna syndrome, basically, but caused by an underlying genetically based SHOX gene mutation, dyschondrosteosis, and Madelung deformity. She had never known about that. She has lived a normal life, and she has never had any surgery until she saw me. I treated her similarly to what I would do for a rheumatoid wrist type in this age group. So I worked on the distal ulna, remodeled it rather than performing a Darax that would destabilize it too much. I remodeled the distal ulna, created a flap of retinaculum to cover the distal ulna, and then reconstructed the extensor mechanism. And she was happy. I mean, considering the age, it was low functional demand, so I didn't need to do much more than that. Another fact we need to bear in mind is that we see in the textbooks all the time that Vickers ligament, which is a traditional description of the ligament, is a radiolunate ligament. It's not really completely always a radiolunate ligament. We can see it on these MRI scans. You see the ligament volar to the radius attaching to the lunate. However, if you look better, most of the times you will see that it can also attach to the triquetrum. Again, it's sometimes combined lunate and triquetrum, sometimes just triquetrum. So it's a radiocarpal ligament. This is just an anatomical definition. So it doesn't really have any functional implication, in my opinion, to know that whether it's attached to the lunate or triquetrum. It doesn't really change much, but it's for us to know, because we should be all very experienced in anatomy and anatomical variations. The symptoms typically develop late, mid and late childhood, adolescence, or adult life, as said multiple times. And they are mainly pain-associated symptoms. Some patients may realize that they have a reduced wrist range of motion when they start doing certain activities that don't allow them to stretch dorsally the wrist. For instance, the typical patient presenting is a teenager who starts to do gymnastics or sports where they cannot fully extend the wrist, and they also start experiencing sometimes some discomfort or pain, which is usually task-related, not all the time, and they present to us. It's usually caused by ulnocarpal impaction. There have been some variations. Some patients present with different symptoms, and they're a bit more difficult to treat because they may have discomfort all along the forearm also caused by the radioulnar instability. As I mentioned, we don't really have a druge. The radius is also short in some patients, so even the proximal radioulnar joint is not perfect. So again, the pain can be caused not just by the impaction. I would say impaction is probably 99% of cases, but in 1% of cases, or a percentage that I don't know, unfortunately, there are other reasons, even the instability. And there have been spontaneous extensor tendon ruptures described in the literature, although rare. And I know that some people may not fully believe in this because it has occurred to me during a few conferences that people said, I've never seen an extensor rupture. Well, I've seen one, but I've seen one. So it was definitely an extensor rupture caused by a long-standing Madelung with an abutment into the tendons. And they were described by Philippe Safar, Caroline Leclerc, Blair and Jepson. So there are cases. There are not many, but there are cases. Ulnocarpal impaction can vary significantly depending on the extent of the anomaly. As you can see on the left side, we've got a typical Madelung deformity. On the right side, a very severe type after completion of bone growth. That becomes really difficult to treat, especially in light of the slope you have on the distal radius. So in this case, I started treating the patient non-operatively and she's been happy. However, the next step could be to consider shortening of the ulna, but then you need to stabilize the radiocarpal joint. So I was even thinking about fusing the radioscaphocapitate joint. But again, there is no report of treatment of these cases. It's all a bit experimental and patient tailored, basically, of the patient, of the single individual. So bespoke treatment for different cases, which is what we often do in congenital hand surgery. Not every Madelung requires surgery. So this may come as a shock to some surgeons. We all like to operate. We all like to see beautiful X-rays. But again, not every Madelung requires an operation. As I said, it's quite rare, actually, the operation compared to the general population out there who is completely unaware of having Madelung deformities. As a matter of fact, splinting, occupational therapy, activity modification can help, and sometimes it's a definitive treatment. Also, sometimes in adolescents with mild Madelung deformity, the pain subsides over time. So again, it's not mandatory, in my opinion, to operate on all patients we see with Madelung. Clearly, we need to be realistic and also explain the potential future risks of increased radiocarpal degeneration, ulnocarpal pain. It can become chronic. We can have ECU tenosynovitis. We can have tendon ruptures. So again, we need to explain what can happen in the future, but I don't think we should operate on all of them all the time. However, depending on the growth potential and on the degree of deformity and on the magnitude of symptoms, we have a lot of options, and we need to arrange appropriate timing for these treatments. In late childhood and early adolescence, we can still release the Vickers ligament and perform a radial physiolysis as described by Vickers himself. It's a bit of a fiddly procedure because we need to put fat graft within the ulnar aspect of the distal radius. And for those of us who have performed it, we all know that putting fat graft into that place is tricky because the fat tends to pop up all the time. So it's very, very tricky, especially the fat interposition. However, the procedure is not particularly complex in itself, and it can be effective. If you do it in an early phase, in the patient of an appropriate age with a good growth potential, you may end up with good outcomes. And you don't burn any bridges. You can still do more in the future if needed. Of course, if it's very severe, you have a very severe shortening of the radius and bowing already, I would consider performing straight away the radial osteotomy rather than doing the radial physiolysis and waiting. So again, release of the ligament, because you tend to approach this wrist from the volar aspect, perform an osteotomy of the radius, and there are different variations. Today also 3D guided possibilities to do so. The ulnar epiphysiodesis may be considered at the same time as the above procedure, but again, bearing in mind, like Apurva was saying earlier on in his presentation, the growth potential of the patient. So I wouldn't do an ulnar epiphysiodesis in a 10-year-old. I would do it probably normally in a 13 to 14-year-old because we have 3 to 4 years of growth potential. Lately, I've started to push a bit the boundaries. I've done it in patients also 12-year-olds, and actually I've been very happy with that, because the thing to consider here is that the distal radius growth is not a normal growth. So we cannot expect the same growth as in individual without Madelung deformity. Therefore, even pushing a bit the boundaries and doing epiphysiodesis a bit sooner than we would do in a case of growth arrest in a healthy wrist can work very well. So I've seen very good outcomes. But still, I wouldn't do it below the age of 12. That's probably my personal threshold. But again, there is no absolute rule about this. It's all about common sense and growth potential and patient assessment. And as for many other congenital disorders, we don't have a perfect answer. We just assess each patient as an individual and see what we can do to improve their life. If the patients present later, so in late adolescence and adult life, then of course the options are more limited. The Vickers physiolysis of the radius is not really an option because you don't have enough growth potential, or you don't have any growth potential to make it work. So you can perform radial osteotomies, lengthening of the radius as appropriate, and ulnar shortening osteotomies. This is the original description of the release of the Vickers ligament with the original pictures of David Vickers. You find these in the Growing Hand book, difficult to find, but again, it's an extremely valuable textbook. And you see the ligament beautifully described. There, Vickers used to perform an incision transversely on the wrist. Personally, I think that it's probably more comfortable to do it longitudinally and also a bit more aesthetic as well, because we need to remember that a lot of these children, when they grow into adulthood and they go for job interviews, if they have a lot of transverse incisions on their wrists, they may be looked at like someone who did deliberate self-harm. And this actually has happened to some people. So again, it's something that we can consider also the aesthetic implication of what we do on these children. And again, this is the physiolysis described by Vickers with the original drawing. On the top, fat interposition, and it allows usually for a good growth of the distal radius. This is a case I performed. I tend to perform it slightly differently. I do not fully detach the distal articular surface of the radius. I lift it more than detaching it because that will continue to sustain, to buttress the lunate. I don't want the lunate to fall in the gap or everything to displace more centrally, because the so-called distal radioulnar joint or distal radioulnar area is very wide here, very unstable. So I don't want the lunate to move more proximally than it should. These are beautiful pictures from a paper from Scott Cousin and Dan Zlotolov, which showed a beautiful Vickers ligament. Those of us who perform this procedure quite often know that the ligament is not always that visible. So it's good to have this kind of pictures to understand what the ligament looks like, because it's part of the capsule. So it's been dissected very, very nicely. And the epiphysiodesis is performed at the same time in the appropriate patient. To perform an epiphysiodesis, you have seen it also during the previous presentation. It's a very simple procedure, although the only difficulty here is to find the perfect placement. You want to damage the physis, you don't want to damage the surrounding metaphyseal or epiphyseal bone. So you need to place it appropriately under image intensifier magnification, and you can use K-wires, curettes, drills. I've used all of them. You can see these are 3 different cases where I use 3 different tools. In terms of osteotomies for the radius, there have been traditional descriptions of lengthening osteotomies with wedges, also multi-level done, or you can use dome osteotomies. This one is the happy face, the smiley face osteotomy, described by the Texas Scottish Rite Hospital group. And again, it's an excellent osteotomy because it allows to correct all planes in the same surgical procedure. So you can work on the dorsal tilt, so improve the tilt of the radius in the volar dorsal plane, and then you can also improve the radial tilt of the radius. There is 3D planning available nowadays. So some of us have been using it for a few years, some others even more so. I know that Takehiko and his colleagues in Japan have started using it a while ago. This was one of the very first descriptions really in 2017 of a case treated performing osteotomies with 3D guidance. And nowadays this is becoming fairly common. However, again, sometimes we need to consider also what's possible in any hospital, because not every health system is able to sustain the cost of 3D planned procedures, and not every patient is the same, and also the previously available osteotomy techniques, in my opinion, are excellent. Anyway, I perform the dome osteotomy still quite often, and I really think it's very effective. This one is a case of a 12-year-old patient. You can see there is quite a big discrepancy between the radius and the ulna, quite a severe anomaly of the radial physis on the ulnar aspect of the radius, and the reduced extension of both wrists in particular. Flexion is usually not affected. Actually, if anything, flexion is very good with these patients. Limited pronation and supination as well. So this is what I tend to do. I perform a reverse, so it's called the sad face radial osteotomy for a reason, because I take a little segment, a little wedge of bone from the radial aspect of the radius and place it on the ulnar aspect. And that allows also to stabilize a bit more the correction achieved. And then use mini plates that can also be 3D printed if needed for fixation. In order to perform these procedures, I nowadays favor using the piezoelectric surgery devices. These ones are devices that we started using, taking them from the maxillofacial colleagues because they are very accurate. They work very precisely. You can carve the bone as you need to. And also because of the ultrasonic vibration, it's micro vibrations of the tip, you do not risk to damage the soft tissues. So it's selective for mineralized tissue. In fact, you need to remove the periosteum when you treat children from the area because it doesn't cut through the periosteum, this device. And it allows you to carve really the bone as you wish. As you can see here on a bone graft that was carving for a distal radial reconstruction in another patient, completely unrelated case. However, just to show you the precision you can use this for. And it's based on a piezoelectric effect of these ceramic discs that vibrate once they are under a source of electricity. This is the same case you've seen earlier on, the one where the limited wrist extension, 45 and 55 degrees respectively on the wrists, and she also had reduced pronation and supination. The case went well, as you can see. So you can see both wrists corrected and improved. The epiphysiodesis of the distal ulna working in both cases. So again, because she still has growth potential, I'm very positive about the future. And these patients tend to be very rewarding for us surgeons because as soon as they improve the range of motion, they feel better and they actually all come back very happy, symptom-free. And it's actually a very rewarding surgery, the one on Madelung, in my opinion. This is a case of a patient, 16-year-old male patient who was studying to become an electrician. So he was struggling to use the screwdriver or any other tools. And an osteotomy of the ulna was the perfect option for him because we are towards the end of the growth. There isn't much I can do at this stage to stop the growth and correct by that natural means. The radius can be improved. You can perform an osteotomy of the radius if you wish to in these cases. You can perform both radial osteotomy and ulnar shortening osteotomy during the same stage. I tend to separate them because in these patients, I don't really like the risk of compartment syndromes, especially in bulky muscular patients like this patient here. So I did the ulnar first, and I was planning to do a potential radial osteotomy later on, but he was happy with this, symptom-free, and he could go on with his studies. But there is a problem. There is a problem we don't talk, I think, enough about, which is the ECU. Because we talk a lot about osteotomies, bones, 3D, which is fantastic. We got a lot of options. But in my experience, and I think that it's a shared experience, but every time I speak with someone, everyone mentions the same problem. The ECU gets extremely painful in these patients because the ulna pushes onto it, and you can see even on the MRI scan, the path of the ECU tendon is very anomalous. It's constantly under strain. So again, we all treat these initially, or I think most of us, non-operatively, with splitting, change of activities, occupational therapy, hand therapy, steroid injections, also bearing in mind that we may weaken the tendon by doing that. But again, what next? When we do an ulnar shortening, I haven't really seen significant improvements in the ECU because the ulna is unstable. As I said earlier on, we don't have a stable distal ulnar joint. So the ulna continues to wobble around underneath the ECU and putting pressure on the tendon. And also correcting the osteotomy of the radius and the ulna, same thing. They don't really solve the problem of ulnar instability. Darax procedures create even more instability, although they reduce the strain on the distal tendon. Reduction of the ulnar head size, I don't know, because again, it's not really a perfect solution, and still everything remains unstable. So what do we do if it all remains unstable? Then we go back to non-operative treatment again, with splinting and steroid injections again. So for me, this remains a dilemma and a challenge, and I would welcome anyone's comment on this. I've even had a patient not long ago who asked me whether I could actually cut her ECU, just remove it completely, which I didn't want to do because, of course, it's still useful for wrist extension purposes, especially in patients who have already a limited wrist extension. However, is that an option? I really don't know whether that could be a good one. However, whatever you do, don't burn bridges. Multiple procedures may be required, especially in light of the growth potential of the patient and also of the occupational needs and hobbies of the patients throughout their life as they grow. But most important, because it's always a complex discussion here with patients and families about risks and benefits, when to do the procedure, staging, growth potential, what procedure to do first, what to consider later if needed, address any unrealistic expectations straight away. So extremely important, the consultation here and the long discussion, because it's difficult to understand as a plan. And last but not least, a fact on the nomenclature, because we call it Madelung, rightly so, because Otto Wilhelm Madelung is the person who popularized the deformity. But the first description was made by someone we know very well as hand surgeons, Baron Dupuytren. So again, it was a Dupuytren's first description, but Madelung, of course, improved the way the disorder was described. He performed a review of the literature. He found other cases as well, described by other surgeons of his era or before him. And he thought that it was all very inaccurate, the way things were described previously. So he put some order in it, and he proposed as a etiology, a primary disturbance caused by joint overloading. He thought it was a repetitive strain injury. Nowadays, we know that is not, it may be the case in a patient or two, but usually we have other reasons for the Madelung deformity. But he recognized that the deformity was more frequent in females rather than in males. And also the symptom onset, also in his age, was about 13 years. So again, very similar to what we see nowadays in our clinics. He proposed a splint made of leather. It must have been very uncomfortable because that's not really moldable that much, around the shape of the wrist. However, he did all these and he started what we now do as treatment of Madelung deformity. Thank you very much.
Thank you very much, Lorenzo. Thank you for a nice talk with wonderful cases. Thank you for showing our case surgical report. Do you have any questions? Okay, Dr. Wan, any suggestions on avoiding or treating secondary dysrhythmia arthritis that may occur following corrective osteotomies of radius and ulna in older adolescents and young adults with Madelung?
Yeah, the thing is, I think that the arthritis goes mostly by the instability of the ulna. However, I also have a feeling that the instability is a protective factor in a lot of patients because there isn't any increased load on that joint caused by the changing in alignment of the radius, because in fact we're increasing the radial tilt of the radius. We are not bringing it ulnerwards. Clearly, the fact that it's an anomalous joint, we don't really have the radial ulnar joint. We have part of the radial physis, which is basically the radiocarpal joint articulating with the distal ulna, but very loosely, makes, in my opinion, almost impossible to prevent degenerative changes because it's completely anomalous, the joint.
Okay.
I wish I could have an answer for this. Good question.
Yeah. And I think another good question from Andres. Great talk. Agree with that conservative treatment for many patients, but what about with the asymptomatic patient that start with mild symptoms with gradually intensification? When you pull the trigger for surgical indication?
Good question, Andreas. It's always a dilemma, and I experience the same dilemma every time I see a patient because as we know, everyone has different needs, functional needs, different way of expressing the symptoms they experience. Sometimes they're really generic symptoms. Some patients tell you they got pain along the forearm, which could well be caused by the instability, of course, between radius and ulna, and by the extensor tendons put under strain. Some other patients identify a very clear site, which is the ulnocarpal region. So to be honest, the ones that come telling me that the pain is definitely ulnocarpal, and they convince me that the abutment is the only reason causing pain or the main reason, I tend to treat also surgically if the pain doesn't subside with a few months of splinting and non-operative intervention. So I don't wait too long for those patients because they come to me specifically because they cannot perform what they want to do. And I think that our aim as hand surgery is to improve patients' lives. So if they want to perform a specific task, we need to try at least and help them perform it. Clearly, within the limits of reason, of course, if they want to do something which is completely inappropriate or unrealistic, we need to be able to advise them against doing it. So the timing is tricky, but I really base my decision on two things. One is the severity of the deformity. Of course, in a mild Madelung with intermittent symptoms, where the patient can wait a bit and see whether non-operative treatment improves the symptoms, I tend to wait a bit longer, but I keep them under review. I don't discharge them. I don't just say goodbye. I just say, let's come back in 6 months and have a look again. And sometimes they don't come back because the pain disappears. But once they come back, and you come back once or twice, then I start asking myself, is it time to operate? And it becomes a discussion with the patient, and when they're, of course, under the age of consent, with the family. And based on that, we made a plan. So again, I pull the trigger based on the symptoms and on the type of symptoms in particular, and also on whether the symptoms persist or improve after an initial trial of non-operative treatment. But in patients with extremely severe Madelung, then I tend to recommend to start considering some treatment because in the future that can cause other problems.
Okay, thank you. And from Apara, when performing corrective ostomies, any technical parts to improve the cosmesis? Many patients seem to be bothered by the appearance in the sagittal plane.
Yeah, that's a good question, Paul. I tend to overcorrect a bit. So, absolutely, the patients are upset, bothered by that also because when they, especially girls, when they wear a bracelet on it, the bracelet drops down. It's not really, actually makes it even more noticeable. So I tend to overcorrect the radius a bit, also because with growth, things tend to change again. And the main issue we have is that they have an excellent flexion, they don't have a good extension. So I tend to provide a better extension by a bit of overcorrection. Yeah.
Okay, thank you. Any other questions or comments? Okay, I have one simple question. Martin may include the possibility of systemic symptoms such as Lely-Weill syndrome or Turner syndrome. If you find the Madelungs, do we need to check the genetics with the pediatrician?
Thanks for this question, Takehiko, because it's a topic very dear to me. I'm lucky because I have my own surgical clinic where I see patients, but also I run a clinic with a geneticist where I learn every day from her because, of course, there are a lot of syndromes and disorders that come under the daylight there, and I would have not considered as a surgeon because they're extremely rare. So a geneticist is extremely important. So yes, a collaboration with a geneticist. I don't, of course, not everyone can have a geneticist in clinic with them, but if you have a geneticist in your area, you should consider referring for screening because it's rare to have severe disorders associated with Madelung, but they do exist. And even knowing that there is a shock gene mutation may help the family know why everyone in the family has short stature, or also predict what's going to happen to the next generations. They may get Madelung, so they already know and come prepared, and they bring their children when they grow older to see you, knowing that it's not a terrible disease, it's just an anomalous shape of the forearm, not just the wrist, and can be treated.
Okay, thank you. Thank you very much. Thank you, Lorenzo.
Thank you.
Okay.